Causes of death remain a difficult statistic to collect in many low and middle income countries. India was in the same situation up till 2004. To address this gap in knowing how people died in India, the Registrar General of India, and led by Jayant Banthia, introduced the Million Death Study in 2002. The Million Death Study implements 6 monthly surveys of more than 1 million households randomly selected from the preceding census across all parts of India. And these are in about 8,000 small areas of India, which each have roughly 120 or so homes. So total, you have about 1 million homes surveyed each of these rounds. How does the Million Death Study work? What it involves is having a verbal autopsy to be integrated within the sample registration system, which is an ongoing, continuous household repeat survey done every 6 months. In each of these 8,000 areas that are covered in the sample registration system, there lives a part-time enumerator, usually a school teacher, who continuously records every month the births and deaths. Then every 6 months, the Registrar General of India sends one of 800 trained staff to independently collect the same information: who's born, who's died, who's pregnant in each of the household. And if a death has occurred in the preceding 6 months, they complete what's called a verbal autopsy form. A verbal autopsy is a structured interview of the living respondent, usually someone that lived with the deceased person, and it's conducted by using semi-structured questions and checklists along with a written narrative in local language. And the written language narrative captures the signs, symptoms, and events, focusing on particularly about 9 to 12 key symptoms. These records are converted into electronic records and sent to 2 of 350 trained physicians who independently assign a cause of death using the ICD-10. If they disagree, they get each other's forms, and if they continue to disagree, a senior physician adjudicates. There are other quality control systems in place on the quality of field work that make the overall system reasonably robust. Verbal autopsy has its limits. It works quite well for early and middle ages, but it doesn't work so well at older ages. And this is because the symptoms that are used to identify the cause of death can often be multiple at older ages. At older ages, people can have both, for example, diabetes and an infection and a previous history of heart disease and kidney problems. So all of these make the interpretation more difficult in older age. But that's actually not so bad news, because the overall age profile of deaths in low and middle income countries is still young. Most deaths occur before old age in low and middle income countries. And at these ages, verbal autopsy works quite well to give a broad cause of death. Moreover, many deaths still remain ill-defined, and that's just part of reality. Sometimes you simply don't know how a person died. And one of the approaches of the Million Death Study is actually not to bury this information on ill-defined deaths, but actually to use it. That allows a check to see whether the field work is being done correctly. And over time, the ill-defined deaths before old age should actually decline. That's a measure of quality. There are other problems, of course, as you can imagine. People may not be willing to give all of the information in a forthcoming manner, but the rapport between the field staff, because it's a continuous survey, means that usually they get pretty good information from the household or someone who knew the deceased person. There are other possible technologies that now are being applied to the Million Death Study, which involve electronic field recording and electronic coding by physicians using online tools, online training and certification, and most recently using global position satellites or GPS to be able to track the location of each death. Now, the Million Death Study tool is not the only method to determine causes of death. The World Health Organization has recommended a similar tools which relies far more on checklist questions and uses only a minimal narrative. They both have their strengths and weaknesses, but the key point remains that either of these instruments, if used properly in a random sample of deaths with careful coding of the causes of death, can give extraordinarily useful information. To conclude, the major gap in knowledge on causes of death is in low and middle income countries and can be filled by adopting a nationally representative survey of the causes of death, ideally a continuous survey such as India's sample registration system.